Dear audience, let me introduce my PhD thesis, which is infections in fibrosing interstitial lung diseases. My name is Zsombor Matics. I work in the Department of Pulmonology in the Semmelweis University, and I am an internal medicine specialist, and my second specialty will be Infectology, because I'm interested in infectious diseases. That's why I have a vision that Infectology will be an inseparable part of the evaluation of interstitial lung diseases. And I have a team supervised by Veronika Müller, and we have ambition to provide evidence-based data that draws attention to the importance of infectology. I have two projects ongoing. The first one was started in September of 2023, and it's called Comparing the Effect of Antifibrotic Treatment on the Incidence of Respiratory Tract Infection in Idiopathic Pulmonary Fibrosis. It's a systematic review and a network meta-analysis, and I plan to submit it in a month. The problem with IPF is that the disease is rare but deadly, with a median survival of 3 to 5 years. And the best treatment which can be given to the patients are antifibrotic drugs, but they can only slow down the progression of the disease. So we know that antifibrotics reduce the investigator-reported acute exacerbations and mortality as well. And behind this high mortality, acute exacerbation is the #1 killer in IPF. And it can be triggered by many things, but infection is the most important because we can impact the numbers of infections, and reducing the occurrence of infection is one of the most crucial things in preventing the evaluation of the pathogenesis of chronic lung diseases and acute exacerbation of IPF as well. So we know that antifibrotics reduce the occurrence of acute exacerbations, but we don't know if any antifibrotic reduce the incidence of respiratory tract infections. So our aim is to investigate the effects of different antifibrotic treatments of IPF on the incidence of respiratory tract infections. Our clinical question is, does any antifibrotic drug reduce the incidence of respiratory tract infections in IPF? And our hypothesis is, yes, some antifibrotics reduce the incidence of respiratory tract infections. So we conducted a systematic search with this search key, and after the selection, 23 eligible full text remained for the statistical analysis. And here let me introduce my results. Here you can see all my included studies in this slide. And my outcome parameters are the incidence of respiratory tract infections. And we aim to do this study because reducing the incidence of respiratory tract infections is one of the most crucial things in preventing acute exacerbation, which is the #1 killer. And the incidence of respiratory tract infections can be very high in an untreated IPF. The range stands between 20 to 70%. So that's why we wanted to check whether those antifibrotics works well only, which reduces the incidence of respiratory tract infections. So we included 23 randomized control trials, and the highest heterogeneity can be seen in the pirfenidone group, where capacity 4 and 6 are outliers because they use different dosage of the antifibrotic drugs, and they reported only serious adverse events and serious infections, so that can be the cause of the high heterogeneity. And as you can see, based on a 52 weeks of treatment period, the currently used antifibrotic drugs, named as nintedanib and pirfenidone, reduce the incidence of respiratory tract infections. Now let me talk about these results briefly in details in the next few slides. So here you can see my results based on the currently used antifibrotic drugs. We compared nintedanib and pirfenidone to placebo, and we included 7 randomized control trials, 4 regarding pirfenidone and 3 regarding nintedanib. I have already mentioned the high heterogeneity in the pirfenidone group, and based on the 52 weeks of treatment period, as you can see, nintedanib decreased the relative risk of the incidence of respiratory tract infections by 11%. And it is clinically very important because, as I said, the incidence of respiratory tract infection can reach 70%, so decreasing it by 11% is clinically very important. Although our results are statistically not significant, but we can clearly see a tendency in the reduction of the respiratory tract infections, so further studies could lead to significant results. We cannot say the same in the pirfenidone group, where there are 2 randomized control trials where pirfenidone increased the risk of the incidence of respiratory tract infections. So now our next step was to compare these two drugs together. So that's why we conducted a network meta-analysis. We included 7 studies to our network with more than 3,000 patients and almost 1,000 number of events. And you can see our results here in the league table. On the right upper corner, you can see the direct comparisons, and on the left lower corner, you can see the direct and the indirect comparisons. And as you can see, the incidence of respiratory tract infections with pirfenidone treatment is 0.91 times lower than with nintedanib treatment. We did an overall ranking. We used the random effect model and calculated the p-score. And as you can see in this table, for the patients, pirfenidone is the best choice. But again, our result is statistically not significant. And we conducted a confidence rating with cinema. And because of the relative high risk of bias and the relative high heterogeneity and the high imprecision and incoherence, we had a very low confidence rating. So we have some strengths and limitations. We pull data only from randomized controlled trials with high number of patients and events. This is the first network meta-analysis regarding this topic, and it's clinically significant, but we have some limitations as well. We have some concerns and high in risk of bias, very low and low certainty in the grade assessment, and a very low confidence rating in the cinema. So our conclusion is, despite the clinically significant differences, there is no statistical significance between the currently used antifibrotics yet. So clinicians can freely choose between the two drugs regarding reducing the infections. And further comparative studies of those regimens might reveal the clinically most beneficial treatment. So my first project is in an advanced stage, and I have already started to write the manuscript as well. And my second topic, called Comparing the Effect of Different Immunosuppressive Treatments on the Incidence of Infections in Scleroderma-Related Interstitial Lung Disease. This is a systematic review and a meta-analysis, and I plan to submit it until November. The problem is that ILD is one of the major forms of lung involvement in patients with systemic sclerosis limiting survival. And the prevalence of ILD approaches 50% of patients with diffuse cutaneous systemic sclerosis. So we know that ILD plays an essential role contributing to the death of patients. And we know that we can reduce the incidence of developing ILD by treating the patients with immunosuppressants. But this is a risky treatment because they also increase the risk for infections, which also leads to death. So, our clinical question: is there an immunosuppressive therapy that reduces the incidence of infections compared to others? We use a PFO framework to answer that question, and our hypothesis is some immunosuppressive treatment comes with a reduced incidence of infections in scleroderma-associated interstitial lung disease. And it is very important because if there is a correlation, then we can rank the available immunosuppressive treatment based on their effect on treatable threats, such as infections. So we conducted a preliminary search with this search key, and we have our essential key articles, which contains all the necessary outcome parameters for another systematic review and a meta-analysis, and I started to register my Prospero as well. So to summarize, I have 2 projects ongoing, and I plan to submit them until March and until November. And here I want to thank you for your attention with the words of Eleanor Roosevelt: do one thing every day that scares you. Thank you very much.
Thank you very much. Excellent talk, Zsombor. I have a question, Zsombor. After your presentation, I've seen that maybe this, regarding your first project, this antifibrotic therapy maybe can reduce the incidence of the infection. And I understand that this antifibrotic therapy are able to reduce the progress of the disease or just preserve the lung function of this patient. But I don't fully understand the link between the antifibrotic therapy and the prevention of infection. Maybe these drugs have any antiviral effects or some prevention on the lungs, or I don't understand. Could you help me, please?
Yeah, we don't know about these direct effects on viruses or any bacteria, but we think that with reducing the decline of the forced vital capacity, so reducing the progression of the disease, maybe the incidence of the respiratory tract infection will be decreased as well indirectly.
So maybe it has an indirect
Yes.
effect. Right, thank you.
Actually, that's why we use the PECO framework, because, yeah, it's not an intervention for the...
Thank you.
Congratulations for the presentation. I'm not familiar with the pulmonology, and I would like to ask that how can I imagine acute exacerbation of IPF?
Yeah, so it's kind of similar, like an acute exacerbation of the COPD, for example, but actually not the same. The symptoms come very rapidly. The patients complain about shortness of breath, sometimes chest pain and dyspnea and coughing. But actually on the chest X-ray, there will be new opacities, and the forced vital capacity will be decreased very rapidly, and usually the duration is within a month.
Thank you very much.
Thank you.
Congratulations, Zsombor. Thanks a lot. And I was just thinking that because your confidence interval is actually overreaching the line of unity. So this also means that there is a statistical chance that infection will be higher.
Yes.
So is there any measure that you can individualize your treatment in a way that you can select those patients who would benefit the most in this regard, or it's really we just have to accept that yes, infection can also occur in these patients? So that is the question. And just one comment, that in your conclusion, I would be a bit more modest and just say that clinically relevant or potentially important, but I would not use the word in your paper as that significant, because by definition, I mean, you give some fuel to the reviewers, that's a sitter, but just this minor comment, but really. But again, congratulations, and I'm looking forward to your answer.
Yeah, thank you very much. Actually, we plan to do subgroup analysis to determine for which patient population is the most beneficial this treatment, and we have ongoing analysis about them.
Thank you, Zsombor, for the nice presentation. I was wondering if there is any curative options for IPF.
So there are no medical options for curing IPF. Only lung transplantation can be curative.
I see. Thank you for this.
Thank you very much.